Hello, welcome to Expert Perspectives from the 20th Annual NOCR Meeting, once again at Caesars Palace in beautiful Las Vegas, where it's been cool, rainy, and windy. But nonetheless, we're having a great time. It's been a really interesting meeting thus far. This has been day one, and today's focus has primarily been on breast cancer and GI malignancies and some additional data on immunotherapy. But right now I'm meeting with Dr. Ruth O'Regan from Emory University's Medical Center, and we're going to talk about what was discussed during the morning session on breast cancer. So Ruth, welcome to Expert Perspectives.
Thank you, Jim. Thank you for having me.
So you're the expert, and we're here to get your perspective. So we developed this agenda this year to try to add highlights from San Antonio. We used to do a lot of San Antonio Breast Cancer Symposium highlights. We haven't done those in a couple years. So I thought this would be a good time to bring that information to the attendees at the annual meeting and to everyone who's out there viewing our expert perspective. So there were a number of speakers in the session that you moderated today, and Christy Russell kick things off talking about screening and prevention in breast cancer. So there's been a lot of controversy about screening. How valuable is mammography in the 40 to 50 age group? How valuable is it in the 50 to 69 or 70 age group? What seems to be the bottom line on the role of mammography, especially in patients who seem to be at higher risk by the Gale model?
Well, I mean, I think definitely mammography is back in the news big time again. And it kind of all started, I think, back a couple of years ago with this SEER registry review that was published in the New England Journal of Medicine, where they basically suggested that about 30% of breast cancers that were diagnosed by mammography were actually an overdiagnosis. So that kind of spurred off a big controversy, and kind of there was a lot of anti-screening rhetoric that came out. And then within the last few weeks, there was also an update of the Canadian study, which basically showed that mammography didn't appear to have a significant effect on long-term breast cancer survival, or at least on breast cancer mortality. Now the problem is, and Christy actually went through this very well this morning, is that these trials that we have for mammography, there's a lot of issues with them, particularly with regard to the control arm and the fact that a lot of these patients actually had mammograms even though they weren't supposed to by the design of the trial. The other thing I think that's interesting is this whole idea of overdiagnosis, because the definition of overdiagnosis is that a woman is diagnosed with a breast cancer on a mammogram, but she doesn't die from breast cancer. Well, that doesn't really take into account at all the fact that we have good treatments for breast cancer. And certainly there are some of those cancers that maybe low-grade estrogen receptor positive breast cancers that maybe wouldn't have affected their long-term outcome. But what about triple negative or HER2 positive cancers, where we know we can cure them with systemic and local treatment, and they must make up some of this 30% that were described in the New England Journal of Medicine paper. So it's very complicated. I mean, I think we all know that mammograms are not perhaps the most ideal screening test, particularly for patients who are premenopausal, and it would be nice to have perhaps another cost-effective other type of screening assay. But I think overall there is a benefit from mammography, but I think women probably should be told that they're not 100% and that they're not going to pick up every breast cancer essentially.
Right, I think just because mammography picks up earlier lesions and ones that perhaps are not going to cause mortality, they're still going to cause morbidity. And ignoring them or letting those breast cancers go until they are a really serious stage doesn't make a whole lot of sense.
No, I agree with that. And actually, the other thing that Christy showed this morning is that there's no question they do pick up smaller breast cancers. So I think, the other thing that I would say about a lot of these studies is there's nothing regarding breast cancer subtypes. They kind of lump all breast cancers together, for example, which again is another weakness of these studies. And the other point to make is that I think a lot of our mammography technology right now is much better than it was when these trials were initially designed. So I think it's going to continue to be a controversial area, but it's really set off both in the scientific community, but also in the media, a lot of controversy about whether screening is of value and who should have it and all those kind of things. So it continues to be kind of a moving target, I think.
Right, and while self-breast examinations are often pushed, they're not all that terribly effective as far as diagnosis is concerned. And you really get the idea that this is going to push a number of women away from mammography, women who really need to be screened.
Well, I mean, I think that's the big concern with this, particularly women that perhaps are at higher risk. I think that's why we have to be very careful about this. And, as we know, the media tends to spin things and, people hear what they want to hear. But I think that's the message to get out, that it is important to follow the guidelines, probably of some of the societies like the American Cancer Society, who do recommend mammograms starting at the age of 40 up until about the age of 75 or depending on comorbidities. So I would follow those guidelines, and because I think that I'm not sure that the studies that have come out recently really are changing any of the guidelines that we currently use.
Yeah, and I'm not aware of any group of women that you can say these women absolutely don't need to be screened during their lifetime. I mean, I think everybody, some patients may need screening more regularly or more importantly than others, but I don't know that there's any group that you could say don't need to be screened at all.
No, absolutely. We don't know who those people would be.
Right. The
same way we don't know what breast cancers are not going to long-term cause, as you said, an increase in morbidity or potentially an increase in mortality in patients. We just don't know the answers to that essentially at this time point. So I think the message should be they're not 100%, but you should follow the screening guidelines that have been put out by the societies in this country.
So, and then what about prevention? I mean, there's been data from the P1 trial and other trials that tamoxifen is effective as a preventive agent in women who are at higher risk, but we know it's got some side effects. There was a trial with exemestane, and then at San Antonio, there was the IBIS-2 trial with anastrozole. But not many women are really taking preventative medicine. What is the story there? Why are preventive medications not being used more frequently, and what seems to be the hang-up?
Well, I mean, I think, first of all, we have patients who actually have breast cancer who won't take these medications, so perhaps it's not surprising that they're not utilized to a great extent in the preventive setting. I think if you look at the trials, all of them have a very consistent message where they reduce the risk of estrogen receptor-positive breast cancers by about 50%, and the IBIS-2 trial was no different with regard to that. I think one of the things we struggle with is that the only one of these agents right now that can be used in premenopausal patients is tamoxifen. The aromatase inhibitors and raloxifene are not. You can't use them in postmenopausal women. And certainly in my practice, the women that come into me that kind of are at high risk for breast cancer are generally premenopausal patients. But again, the success rate of them actually starting on these medications, I would agree with you, it's quite low. I think that if you have a premenopausal patient who's, in their perhaps like late 30s, early 40s, that's an opportune time to think about tamoxifen because they usually tolerate it quite well. They're not at risk of uterine cancer at that age because they're premenopausal, and they've done their 5 years, and we know that the preventive effect of these agents does last beyond 5 years. But I would agree with you, I think the pickup for postmenopausal patients has been very low, and I'm not really sure why that is because there's no question these drugs work. But I think it's just the fear of toxicities more than anything else is what's kind of turning patients off, or turning women off taking these drugs.
Right. So Bill Gradishar talked about endocrine therapy, and one of the things he focused on was discontinuation rates and causes of discontinuation, especially with aromatase inhibitors. So what kind of conclusions can we make from the data from San Antonio regarding the aromatase inhibitors and why some women are willing to continue with them and some discontinue? Is it toxicity? Is it cost? Just what seems to be the problem?
Well, so as you know, compliance with endocrine therapy for 5 years has been reported to be very low in some studies. I mean, as low as 40%, which is really shocking because we all know how very important these agents are for patients with ER-positive breast cancer. The aromatase inhibitors have been very interesting because I think the whole issue with the musculoskeletal issue, symptoms that you get with aromatase inhibitors wasn't really predicted at all from their use in the metastatic setting. And from a biological point of view, we really don't know why women get these joint pains and muscle pains that they get, but they can be very severe, and we all have patients that just cannot take these drugs, and it's really a huge issue. So at San Antonio, one of the first abstracts was looking to see if baseline symptoms really correlated with the likelihood of remaining compliant with an aromatase inhibitor, and there wasn't really too much in that abstract. You know, the interesting thing was a lot of these women had baseline issues with joint pain and muscle pain before they actually even started taking the drugs. And it does appear that some of these musculoskeletal issues are something that you see with natural menopause, which of course is something that we induce with the chemotherapy that we give. Again, from a biological perspective, we just don't really know why that is, essentially. So then the second abstract was looking at exercise. So it was actually a randomized trial. Patients taking aromatase inhibitors were randomized to exercise or to usual activity or whatever. So the exercise was about 2.5 hours of aerobic exercise a week, and then some strength training sessions as well. And they did find that helped in terms of the symptomatic issues that the patients had with aromatase inhibitors. But again, we encourage exercise for our patients anyway, so it's not really that practice changing.
But it just gives you some more evidence to convince them that exercise might really be beneficial and might make them feel better.
Yeah, absolutely. So I think, you know, obviously recommending exercise is kind of a no-brainer for these patients, but this could be an added benefit from that. And then, you know, the last abstract was looking at what's happened since the aromatase inhibitors went generic, and it does appear to be better compliance now that they're generic because, of course, they're much cheaper. So cost was clearly an issue before, which has been kind of, I think, at least partly taken out of the equation at this time point.
Patients were skipping doses or going every other day or this sort of thing because of the cost.
Correct. And, you know, remember when these drugs came out first, the doses all came out of the metastatic setting. So they have been, the doses were established by, you know, comparing one dose to another. So, you know, there's really no data support doing lower doses or every other day scheduling or this kind of thing. So we have no idea whether that's going to be effective for patients.
Great. Well, what new has come out of San Antonio and other studies as far as HER2-positive breast cancer? And we've had trastuzumab for many years now, and then lapatinib came along, but seems to have sort of fallen to the wayside. Pertuzumab has been approved, and TDM1 has been approved. What new data was there in San Antonio?
Well, actually, interesting that there wasn't too much on with pertuzumab or trastuzumab DM1 at this meeting. Interestingly, it was a little bit more, less is more. It was kind of more of the kind of message that came out of this meeting. I think one of the interesting things was we all struggle with this treatment of small HER2-positive cancers, and the Dana-Farber group had done a straight phase 2 study looking at HER2-positive cancers that measured less than 3 centimeters, where they just gave 12 weeks of paclitaxel along with trastuzumab and then continued trastuzumab for a total of a year afterwards. Now, it was a straight phase 2. There was no comparator arm, but what they found was that the 3-year disease-free survival was incredibly favorable in these patients. It was up around 97%. So really a very effective regimen, even though it wasn't compared to standard of care. So I think that was very interesting, and I know some of us have been doing that anyway, particularly with older patients. So I think for these small HER2-positive cancers, there may be a little bit of a move to try and cut back on the chemotherapy a little bit and kind of look at...
Avoid the anthracyclines.
And certainly avoid the anthracyclines, absolutely. So that was an interesting abstract. Then we had a presentation on the BETH trial, which is an adjuvant trial looking at the addition of bevacizumab to trastuzumab-based chemotherapy. Patients could get either TCH chemotherapy or an anthracycline-based chemotherapy. The majority of patients on the study did get TCH. So it was essentially TCH with or without bevacizumab. And unfortunately, it was completely negative. There was no benefit for the addition of bevacizumab, and we had the usual toxicities that you see with that drug as well. But again, in that study, the patients really had a very favorable outcome in the non-bevacizumab arm as well as the bevacizumab arm. So these patients really are doing very well with the regimens that we currently have available.
Right. One of the confounding situations that oncologists sometimes see are those patients who are ER positive and you think they should have a good prognosis, but they're also HER2 positive, which is usually a negative factor. how do you determine or how do you decide how to manage those patients? And you spoke on that at the meeting this morning.
Yeah, I mean, it's a complicated situation because we've always thought that if you have HER2 and estrogen receptor present in a breast cancer cell, that HER2 is driving the cancer, and that the estrogen receptor, you don't ignore it, but it's not as important as the HER2, positive aspect of the cell. And that's essentially why the standard of care is to recommend HER2-directed therapy with chemotherapy for those cancers. However, I think there's some emerging data coming out that some of these ER-positive, HER2-positive cancers may be driven by estrogen receptor, which might explain the intriguing finding that across the board in the studies that have looked at the preoperative use of trastuzumab-based chemotherapy for HER2-positive disease, the pathologic complete response rate is always higher in estrogen receptor-negative cancers compared to estrogen receptor-positive cancers. On top of that, we had a presentation at ASCO where they did intrinsic subtyping on HER2-positive cancers. And the ER-positive, HER2-positive group are very heterogeneous. And what's very interesting is about 40% of them have a luminal A phenotype, which we know is driven by estrogen receptor. Right. So I think we really need to do better molecular analysis of these cancers and try to determine if there's a group where you could just basically treat patients by blocking HER2 and blocking estrogen receptor and not give them chemotherapy, because there is extensive crosstalk between these pathways.
So that's very interesting. So finally, triple-negative breast cancer, Debut Tripathi spent some time talking about that today and the genomic analysis and deep exome sequencing of some of these patients. Where are things headed in triple-negative?
Well, I think there's some very exciting research being done in triple-negative breast cancer. I think the only real thing that was potentially practice changing at the meeting was the CLGB study, where they looked at adding in either carboplatin, bevacizumab, or both into paclitaxel followed by AC. And what they showed was that the addition of carboplatin to paclitaxel followed by AC did increase the pathologic complete response rate, which we know is a very important predictor of outcome for patients with triple-negative breast cancer. The bevacizumab, there was a non-significant trend to it improving pathologic complete response rate as well, but it wasn't statistically significant, and there was quite a bit of toxicity in that arm. It's probably not quite ready for prime time at this time point, because by adding in carboplatin in with paclitaxel, there was quite a bit of toxicity, and it also affected the ability to deliver the dose of paclitaxel. But it is interesting, and I have to say I would consider doing it in a patient. If I started with AC and perhaps they didn't respond very well, I might consider adding in carboplatin with paclitaxel for a patient like that. So that was the main clinical trial that was presented, as well as some interesting data looking at adding a PARP inhibitor with carboplatin to paclitaxel as well from the I-SPY 2 trial. Again, not ready for prime time. It has to be confirmed in another study. But really, I think what's most interesting about triple-negative breast cancer right now is the molecular analysis that's being done, the Vanderbilt subtyping showing these 6 different subtypes, which unfortunately probably need different treatment approaches. So we're all going to have to work very closely together to try and develop trials specific for these subtypes, given the fact that triple-negative is one of the least common subtypes of breast cancer that we see.
So does it look like the platinums work best in the basal subtype, or is there also activity in some of the other Vanderbilt subtypes of triple-negative?
I don't think we know at this time point. Traditionally, we do think because the basal-like is associated with BRCA deficiency, we know platinums are effective in that group. I think overall there is a general feeling that there is more sensitivity to platinums when you've got a basal-like kind of a phenotype versus the other ones. But across what we know so far about the different subtypes, it's quite minimal in terms of using those subtypes to basically choose treatment. But I will say that the luminal androgen receptor subtype seems to be a little bit like the luminal estrogen receptor positive subtypes, in that that subtype doesn't appear to be as responsive to chemotherapy, and that's why there's some interest in looking at anti-androgens in those particular cancers. The other thing I will say is that I think and I would agree with Debut on this, I think where we need to focus our efforts for triple-negative breast cancer is in that residual cancer that's left after you give pre-op chemotherapy, because we're not going to get away from chemotherapy in triple-negative breast cancer anytime soon. And the Vanderbilt group are looking at genes that drive this residual chemo-resistant triple-negative breast cancer, and they presented some data showing that JAK2 is involved in that. And actually the
That's really
amplification
interesting.
is very interesting. The amplification of JAK2 is not seen very often in the primary cancer, but after chemotherapy, the number of the percentage that have JAK2 amplification actually goes up, and then goes up again if they develop metastasis. And that's interesting because the our hematological colleagues have been actually targeting JAK2 with an antibody for years. So I think that's going to be very interesting. So you're going to see a lot of trials in that kind of post-neoadjuvant chemotherapy area.
So the triple negative patients who get neoadjuvant therapy and get a PCR, they generally do fairly well, but so many of them don't and have residual disease. And so those are the ones that really need to be looked at and entered into trials.
Absolutely, because I think that's the conundrum, you know, that there's a group that are very chemosensitive, but it's probably only about a third of triple negative breast cancers. 2/3 of patients do not achieve a good response, and unfortunately, some of the data will suggest that they're destined to relapse in almost all cases. And that's an area where I think looking at target agents makes more sense because the disease is micrometastatic at that time point. If you start looking at target agents in patients with metastatic triple negative breast cancer, you're not going to get anywhere because unfortunately the disease is so aggressive, they typically progress very, very quickly.
Very good. All right, Ruth, thank you so much. This has been great, a good update, and it was a very interesting session in breast cancer this morning. And thanks to all of you for watching this first segment in Expert Perspectives from the 20th Annual NOCR Meeting. I hope you will check in with us later for GI cancers and thoracic malignancies as well. Thanks so much.